All right, good morning, everybody. I'm going to go ahead and get started with the pediatrics portion here. We have a couple of housekeeping things to kind of go over before we get started that Sarah has asked me to go over with you all. I know some of you are filtering out to get some coffee and some water, and as everyone filters out, we can kind of get started here in a couple minutes. So first of all, thank you for being here at the 2021 ERAS meeting here in New Orleans. It's always good to have in-person meetings, and I do want to echo what Dr. Scott said yesterday about finally having in-person meetings and getting to interact with everyone. It's been great. We were just commenting how the meetings have been very small, but as we start to gain confidence and things start to hopefully normalize out, these audiences hopefully will start to get bigger over the course of the year. I do want to highlight that there is still time to sign up for the hands-on ultrasound guided block workshop, which is taking place this afternoon. See Sarah or Heather over on the side if you want to sign up for that. It should be a great session. Again, join us for our educational lunch this afternoon. The topic is going to be the role of a once daily intravenous non-opioid option, and this session is supported by Badeau Bio. At the end of the science today, we'll have a reception in the exhibit hall, and it's a great time to mingle with your colleagues and visit our vendors and support them, of course. Tomorrow morning, just the last piece of housekeeping here, 7 a.m., there is a concurrent specialty session for gynecology and a program organized by the ERAS Nurse Committee and APP Committee, which is Do the Common Things Uncommonly Well. If you're collecting CME credits, know that they're going to send you guys an email, and you have to fill out the evaluation and they can get your credits done. And then if you're not members of ERAS USA yet, please feel free to visit the desk and join us. We're a small group, but we're a powerful group, and I think we do a lot of good for the country and abroad as well. And with that, we'll go ahead and get started with the pediatrics portion. Again, welcome to the pediatric concurrent session. My name is Andrew Franklin. I'm a pediatric anesthesiologist. I have the honor and privilege of leading a fantastic group of like-minded individuals in ERAS Pediatrics, and we're going to spend this morning talking about ERAS Pediatrics and some unique aspects of pediatrics, which hopefully you can take forward to your own institution. So, what are the factors that are unique to pediatric ERAS? And the biggest thing is there's a huge variability in size, right? And so we've heard a lot of adult lecturers this morning and yesterday talk about standard dosing for medications. Obviously, a ERAS pathway or program that is built for infants is not going to work for teenagers, and it's not going to work for neonates. And so there is a significant age and size variability. It's important to do prehabilitation, preoperative carbohydrate-rich drinks, starting enteral feeding. All that stuff is very important in pediatrics as well. However, their nutritional and fluid requirements do vary greatly. Mary Brindle, who's one of our colleagues in Calgary, has done exceptional work on neonatal ERAS, and obviously their nutritional needs are going to be vastly different than your football player that's coming in to get ACL reconstruction. The eligible patient pool tends to be smaller, and so we were talking about knee replacements at our ambulatory surgery centers. We do about 4 knee replacements before lunch, but we may have 4 pediatric colorectal cases in an entire month. And so the eligible patient pool is smaller overall. However, those patients certainly benefit from ERAS as well. Thankfully, the comorbidities of most children are less severe. Obviously, we're not having to deal with all of the cardiovascular and pulmonary issues that older patients have to deal with. However, there are congenital syndromes which may make certain aspects of pediatric ERAS more challenging, particularly patients with seizure histories or congenital syndromes, and so all of those things need to be taken into consideration as well. It's always important to take family dynamics into consideration. Obviously, we deal with families in adult ERAS, but mothers and fathers and uncles and aunts and grannies and grandpas, they all have to weigh in on what should be done for the child, and you have to definitely engage those individuals as well if you're going to have a successful ERAS program. That being said, what are the factors that are similar to adult ERAS? Basically everything else. And so I love this graphic that was put together by two of our fantastic colleagues here, Dr. Heiss and Dr. Raval, who are two big thought leaders in pediatric ERAS. And this makes a lot of sense to me. And so if you take a look at this pediatric ERAS graphic, it's very similar to what you have all seen in adult ERAS. And so basically all of these factors that you see listed here are applicable to pediatrics as well. So how do you get started? Well, the first thing is to grab the low-hanging fruit. And so like with all ERAS pathways or programs that you're starting at your institution, it may feel overwhelming to jump in, but carefully look at your surgical classes, think about the operations that you do, and then take a look to see which one would be the best to get started with. And it's always important to start out with the one where you can have the most benefit and gain traction as you go. It's always important to track the data. And so if you don't know where you're starting from, you don't know where you're going, and you don't know where your goal is. And so it's always important to track your data from start to finish here. Now, it's really important in pediatric ERAS to find this sweet spot between what I consider clinical expertise, the medical evidence that drives your decisions, the team dynamics at your own institution, and then you have to find what I call safe sustainability for your ERAS pathway. I think it's fantastic to say we're going to do, erector spinae blocks for all of our spine patients. There is some literature to support that, but if nobody on your team does that, and then you run into local anesthetic toxicity issues, it's going to tank your ERAS pathway before it even gets started. And so that's what I consider finding the sweet spot between those four competing forces. So we all remember that Uncle Ben from Peter Parker and Spider-Man has this great quote, which I think about every day when I take care of children. With great power comes great responsibility. All the folks in the audience here have some leadership role within their institution and are looking to start ERAS. It does take great responsibility when you're thinking about starting ERAS for children, because one size does not fit all. Just because the evidence that you read in one study says it's applicable to this patient population, it may not be the greatest fit for your own institution. Now, it's really fascinating and to go back to your own institution and to get really energized about ERAS. But I do want to say with pediatrics, you have to take measured steps. Your ERAS ship can definitely drown in your sea of ambition if you start too fast and you don't think carefully about each step along the way. So again, when we started our ERAS pathways at Vanderbilt, we did our Lean Six Sigma methodology, which is a complex way to tackle this from the top. Right now, we use the PDSA cycle for learning and improvement that a lot of you are familiar with, where you plan, you do, you study, and then you act when you make a change. And then you always have to think about change dynamics anytime you're instituting a change at your workplace here. And so I always come back and I think about the Tuckman team development model. And so this really fits into ERAS, and it really fits in with pediatrics as well. Overall, pediatrics institutions tend to change a little bit slower. They tend to want the data. They tend to want to meet a little bit more because they want to keep everything safe for the child. And so the gears of this Tuckman team model do move a little bit more slowly. So if you think about starting like a lidocaine infusion for your ERAS pathway, the first thing is you formulate that plan. You say, okay, lidocaine's a great idea. And then you go through this storm phase, okay? You always have to anticipate the storm phase where everybody in the workroom is grumbling about Franklin, making me, hang this lidocaine infusion, and they're talking about you behind your back. Just know that that's a normal part of change management. And then it starts to norm, okay? You start to reach this norm where people are starting to get that lidocaine from the pharmacy, okay? They're starting to hang that before the patient comes into the room, and then you eventually will reach that perform phase where the pharmacist will actually look at the next day's cases, see a couple spines on the schedule, and prepare that lidocaine infusion before you even get to the hospital, okay? And so that's the different stages of change management. So with that, let's go ahead and get started here. We have a fantastic panel of experts in pediatric ERAS that are going to talk to you about their areas of expertise. And we're going to start out with Dr. Mehul Raval, who is a pediatric general surgeon at Northwestern University in Chicago. He's going to talk about his multi-center trial, which is the Enrich US trial. Next up, we have Kyle Rove. Dr. Kyle Rove is a pediatric urologist at the University of Colorado, and he's going to talk about his multi-center trial, the PURSUE trial. We have Dr. Megan Brockel, who is a pediatric anesthesiologist, also from the University of Colorado. She's going to talk about unique preoperative pediatric enhanced recovery considerations in that preoperative phase. Unfortunately, you have to listen to me for 20 minutes. I couldn't get a couple of my colleagues to show up to speak because of COVID issues. So I'm going to do both intraoperative and postoperative enhanced recovery considerations. And then we're going to close it out with the case-based discussion with Dr. Catherine LaRusso at McGill University, as well as Dr. Kurt Heiss, who is at Emory University, and talking about practical implementation tips. And with that, I'll go ahead and turn things over to Dr. Raval.
Good morning. Thank you guys for the opportunity to present some of the work that we're doing in the ENRICH-US trial. ENRICH-US stands for Enhanced Recovery for Pediatric Surgery, or Enhanced Recovery in Children Undergoing Surgery. And I'm going to tell you a little bit about the background behind this story, and it starts with giving some acknowledgement to the people that have funded the work that I'll be presenting today. This is a collaborative effort by a group of hospitals that have come together underneath the umbrella of the Pediatric Surgical Research Collaborative. Our initial work, our pilot work, was funded by the Crohn's and Colitis Foundation, and the current trial is funded by the NIH. I'm going to do a whirlwind tour of the basic tenets of enhanced recovery that brought us to the point where we were ready for a trial. And I know that this audience is very familiar with enhanced recovery, and so I'm not going to belabor those points too much, but I do think it's important to kind of go back over that history. And then I'm going to describe just where we are with the study, how it was set up and designed, as well as what the current state looks like. So we all know Heinrich Kellett and the work that he did nearly over 20 years ago, I should say now. And it has taken us a long time to adopt many of those principles into our practice. And I would say that even in children's surgery specifically, we're still about a decade even behind where the adults are. So my journey with enhanced recovery began in 2015, 2016. And what we did initially was a little literature review to see what was out there. And there were quite a few studies that had fast-track protocols or little mini versions of enhanced recovery that had just a few elements as listed here on the screen. Most of them were really focused on trying to get people to have rapid uptake and implementation of minimally invasive surgical techniques. That's really what it was built around. And then along with that came things like leaving some drains and tubes out, like not using NG tubes, and maybe advancing diets faster. And across the board, these studies were impressive. They looked at a lot of different children's surgical procedures, from nephrectomy to GI surgery, and what they were able to show is a dramatic decrease in length of stay with these fast-track protocols. And so the environment was ripe for this. And so what we did next was we wanted to survey our APSA membership. This is the American Pediatric Surgical Association membership. And I would say the vast majority of practicing pediatric surgeons in the United States are APSA members. And so we did a survey, and what was reassuring was not that we had only a 25% response rate, which is actually normal for APSA surveys, but rather that about 60% of surgeons said that they were already implementing or were extremely prepared and willing to implement the vast majority of enhanced recovery principles. In fact, about 14 of the 21 adult colorectal elements were things that people had no problems with at all. So we took those 7 elements that were a little bit more contentious, and we did this modified Delphi process to really determine whether or not it would be okay just to simply adopt what's being done in adults and do it for children. And across the board, after having several rounds of consensus building and debate and discussion, about 5 of the 7 elements made it into the protocol, so to say. The 2 that didn't are on the top left, mechanical bowel prep, which we still probably to this day don't have a great consensus and uniform idea of what the best practices are, especially in children. And in the bottom right, the use of insulin to control hyperglycemia. In the adult world, having teams walking around the hospital with sliding scale insulins and things like that is normal. We don't do that in children. We don't do every 4-hour finger sticks and things like that. So those 2 didn't make it in, but pretty much everything else made it into play. So based on that work and kind of concurrently happening under the leadership of my colleague Kurt Heiss, who you'll hear from in a little bit, we started piloting our enhanced recovery protocol at Emory University, Children's Healthcare of Atlanta, and I'm going to share some of that initial pilot data with you. This wasn't a huge pilot study. It was a single center study. We had about 40 patients in our pre-implementation of enhanced recovery time period and about 40 in the post. Most of these kids had inflammatory bowel disease, on the order of 80 to 90% of them, and the operations that they were undergoing were ileocecectomies and total colectomies, J-pouch creations, and ileostomy reversals. So this is true general GI surgery that was happening. And here's our results. Time is along the x-axis, and the box plots demonstrate the number of enhanced recovery elements that we were doing. And as you can see, it was just kind of gradually and naturally happening to where we were going from about 4 to 5 or 6 elements just over time, getting to where enhanced recovery, different elements of enhanced recovery were becoming a part of our practice. But you see a big jump in 2015 and 2016 where we doubled the number of elements that we were doing, and we took that number up to about 12 to 15 even. In the blue line, that little blue check mark is the length of stay in days. And as you can see, the trend was that we were heading in the right direction, and then we kind of plateaued out at around 2 to 3 days. We started off in this prior period at 5 or 6 days. So we demonstrated nearly a 50% decrease in our length of stay. And it wasn't just length of stay. The other lines, the red lines now superimposed over that length of stay line, represent intraoperative fluid utilization in the top left box, which we decreased by nearly half. The top right is intraoperative opioid utilization, which we took down almost to 0. Bottom left box shows postoperative in-hospital opioid utilization, which once again almost went down to 0. And then our time until a regular diet was solidly pegged at 1 day. Post-op day 1, we were on a regular diet. So from our pilot data, we concluded that enhanced recovery protocols in children, they're feasible, they're safe. We can expect shorter length of stay, less opioid use, with no real increases seen in complications or readmissions. This is just a follow-up study because that little uptick at the end of the check mark bothered me. I wasn't sure if we were going to bounce back up or not. So we followed this up with another year worth of data. And as you can see, it did plateau out between 2 to 3 days. We also looked at post-operative, post-discharge opioid scripts that we were sending people home with. And as you can see in the pre-implementation period, about 80% of our patients were going home with a prescription for opioids, and in the post-implementation period, we dropped that down to about 25 to 30% of kids going home with a script. We're not the only ones that have demonstrated this, and since we published our initial pilot study, there's been some other really nice series published, and I'm just going to mention them. This is the work led by Michael Phillips, one of our pediatric surgical colleagues, and his team out of UNC Chapel Hill, and they have a really unique setting where they have a children's hospital nested within their adult hospital where they already had enhanced recovery in place in the adult world. And many of the children, adolescents and teenagers were getting care at either the adult colorectal surgeons or the pediatric surgeons. So this is a really real-world, pragmatic type of experience that he reported. A little bit larger than ours, about 100 patients in the post-enhanced recovery time period. And once again, most of these patients were inflammatory bowel disease patients. He was also able to demonstrate decreased use of opioids, decreased times with things like the Foley in place, a decrease in length of stay of about a day, and then complications that were stable. The team out of Hopkins also published their experience, and their experience was one where they made iterative plan, do, study, act cycles of enhanced recovery implementation. And once again, most of their patients were IBD patients. They had 4 cohorts where they had early and late implementation as a part of the analysis. And what I thought was really interesting about what they reported was that their learning curve, there was a learning curve, and that they got better and better at implementing enhanced recovery as time went on, and they invested more and more of their energies into the effort. This is the final paper, background paper I'll go over. This is really looking at what was happening at the sites that are in our Enrich Us trial. We wanted to understand what was already in play and what things people were struggling with on the front lines before they even started trying to implement enhanced recovery. And this is a busy slide, but we were able to identify that the things that were happening in the operating room, in the hands of the surgeons, were things that they were already doing a pretty good job at, like using minimally invasive surgical techniques, trying to use regional blocks, getting the antibiotics right, avoiding drains. Those things were things that they were doing well at, even at baseline. But there were a lot of areas for improvement, specifically in the preoperative phase, really engaging with patients and families and making sure that those patients and families were ready for the enhanced recovery experience. And then also many of the little things that we think are happening, like advancing the diet or getting people up and moving, we think they're happening, but the reality is that we're actually not really sure whether those things are happening for each and every patient as they come through the protocol. So that was a whirlwind background of doing a lit review, a survey of the national scene, doing an expert panel, creating a pilot study, doing some pre-implementation work. All of that led up to the R01 that was funded by the NIH and the current study that I want to share with you now. But I just want to share that trajectory, because to me this is one of the most powerful paths that took us on this journey. So right now we have 18 hospitals participating in the trial all across the United States. I've listed those sites as well as their surgeon champions here. At Northwestern, we're serving as the data coordinating center in our hospital, and in Robert H. Lurie Children's Hospital is one of the clinical sites. The way we designed the study was not just to look at the typical pathway you think of when you think of trials. When we think of trials, we always think of the outcome. So here it would be length of stay. We want to power our study to detect a decrease in length of stay. But to me, that's just the tip of the iceberg. What we really want to understand are how are we going about implementing and actually making the changes on the front lines for the patients that we're caring for. And so this is a hybrid type 2 that has an equal focus, not just on the effectiveness, which is length of stay, but also looking at how we're adopting and making feasible and actually sustaining many of the changes that we're making that are part of the enhanced recovery protocol. We're using something called the 5 active implementation frameworks. And these are, this is like a theoretical model that you can apply when you're trying to do quality improvement work. And I'm not going to spend too much time, but I'll kind of highlight one of these main domains, one of these 5 domains that they talk about, and explain it as it pertains to enhanced recovery. So one of the things that people claim is important when you're implementing something new is having the right teams in place. So that's the second row. The teams need to be supportive teams to define infrastructures and support methods and improve outcomes. Well, that makes sense. We can't do any QI without having the right team in place. So our Enrich Us plan to address teams is to create local teams of implementation teams that have surgical champions and anesthesia champions and quality experts and patient representation on those teams locally, but then also to create within our study an infrastructure for these teams to come together and have learning collaboration, where we can say, what's happening at your hospital? How are you navigating those obstacles you're facing? How are you getting that done? Can you teach me how to do it? And vice versa. If we're doing something well at my center, how can we help coach you up? And we can go through all these domains, but ultimately these types of frameworks are really helpful because they can optimize our initial success, mitigate the obstacles that we're facing, foster real collaboration and group learning, and then provide us with a structure and make sure that we have an infrastructure to give people the data that they need. So once again, there's 18 hospitals. They're all depicted in the daisy wheels on the left-hand side of the screen. At each site, these implementation teams are put together, and then 6 sites are randomized to be together as a cluster. So we call them, this is a cluster randomized trial. So we're not randomizing a patient to either getting enhanced recovery or not. We're randomizing your entire cluster of 6 hospitals to step into implementation. I'll explain that more in just a second. But ultimately, creating these local teams and empowering these teams to get the job done is really important. So we've put together a lot of materials on the screen right to help identify the stakeholders, educate them about enhanced recovery, and get them to be a part of the team. So now on screen right, what you see is that step wedge design. You can imagine there's these different teams. They're put together randomly in groups of 6. So the first randomly selected cluster, cluster 1, those 6 hospitals spend about 6 months in what we call the control phase, where we're just collecting baseline data at their hospital. Then they step into implementing enhanced recovery during the intervention phase, and that lasts a year. Those are the 2 green boxes on the top row there. And then they have about 2 years of sustainability, where we continue to collect their data to make sure that the things that they've done during implementation are sticking. Cluster 2, those 6 hospitals that are randomized to cluster 2, they do a year of baseline data collection, a year of intervention, and a year and a half of sustainability. And those that are randomized to cluster 3, they do a year and a half of baseline data collection, a year of intervention, and then a year of sustainability. So that's the step wedge design. We have a fantastic team helping to get this done. Project managers, coordinators, data scientists, research fellows, you name it. The whole, and then we have a lot of collaborators both at Northwestern as well as at Emory to help pull this off. And so I'm going to tell you a little bit about some of the challenges that we've been facing as we've started this trial. The first one is that the NIH has required us to have a single central IRB. And I'm not sure how many of you guys have worked with IRBs, but this is not an easy task. To me, this is a huge misnomer. It was meant to make things easier so that you wouldn't have to have IRB approval at every single hospital that you're working with. So in theory, it's great. The reality is that nobody's hospital will accept a single central IRB, even though the NIH mandates it. And so you still have to get IRB approval to do a study like this. It took us over a year to do that, and I would say $250,000. So super expensive, and we're using an external vendor to do that. Then, as soon as we got through all that, we're ready to get started, and COVID hits. And so this is a study all about elective gastrointestinal surgery. So these COVID delays were very real, and still are. I would say that there are impacts not just from shutdowns and elective surgery delays due to COVID, but now it's due to staffing as a ripple effect of the Great Resignation, as it's called. And so we're all facing these things on the front lines at our respective hospitals. And so these have been really impactful in terms of our enrollment. Our enrollment has been pretty slow. Our inclusion criteria are any 10 to 18-year-olds undergoing elective GI surgery, not just IBD, it's any other GI surgery that's as long as it's electively scheduled. So this could be like a stoma reversal after a trauma or something like that. That would count as well. So we've tried to liberalize our inclusion criteria a little bit. We do still exclude dysmotility patients because I think they're a unique patient population. And then we've liberalized the definition of elective inpatient, meaning it used to be that we said elective meant you came in from home to have your elective GI surgery, but now as we know, there may be someone with, let's say hypothetically, a Crohn's stricture that is in the hospital and is then slated to get their ileocectomy done early the following week. So they could either go home for a few days and then come back for their surgery, or we'll just keep them for the weekend, make sure they don't get obstructed, and do their surgery electively. Well, as long as they've had an opportunity to learn about enhanced recovery during that inpatient hospital stay, we're now allowing them to say that that's relatively elective and be included in the study. We've also had some turnover of the study team. This has been going on now for two and a half years. And so obviously we've had some site PIs change over and data collectors and team members that have to be reoriented and things along those lines. And so those are the realities of trying to run a longitudinal study. Good news is we've enrolled over 270 patients as of this month. And the big yellow arrow depicts where we are. So cluster 1 has been in the implementation phase for about 9 months, and then cluster 2 just stepped into implementation this past month. Cluster 3 remains in the control phase, and so that's kind of where we are in the current state. We have really worked hard to create these learning collaboratives that happen every month during the 12-month intervention phase. And as I mentioned, this is really for opportunities for all the different implementation teams at all the sites to come together and learn from each other. As Dr. Franklin mentioned, PDSA cycles in between each one of the learning collaborative sessions. Each learning collaborative session has a different theme or topic. So for example, hard to read there, but these monthly sessions are very well organized in the sense that we have sometimes outside speakers come and share their experiences. We also have experts in healthcare change management and leadership and things along those lines come and coach the teams up a little bit so that we can navigate some of the challenges that we're facing. We've created a website with all the materials that you could possibly imagine, every type of order set we could get our hands on, different things that we think are going to help the team succeed in terms of implementation, as well as an implementation toolkit bundle that we've put together. We also have created a lot of patient-facing videos to explain the study, to explain some of the aspects of the study, and these are available for free on YouTube. Just type in enrich-us in YouTube, and you'll see a lot of these videos. For example, one of the things that we're interested in is using more mindfulness techniques in the perioperative period. So how to teach people how to do deep breathing, for example, and deep breathing exercises to help decrease anxiety and pain in the perioperative period. Well, many of us are at centers that have like child life experts and other types of personnel that can do that on the front lines, but many of us practice in places that don't have those resources. So we created a quick 5-minute video that kids can watch, adolescents can watch, and I think it's really helpful. But we've been actively trying to put together as many of these types of materials as we can. Here's the kind of reports we're able to put together from the data that we're collecting at all 18 hospitals. We can look at different specific, this is for cluster 1, this is from a few months back, but we can look at different elements of enhanced recovery to make sure that people are getting into the green zone, so to say, with each of the elements. So The top one is intraoperative antiemetic use was relatively low across the clusters, across 6 hospitals, and so we really focused on that, and so on and so forth. Here are the 6 hospitals in cluster 1, looking at the overall completion of enhanced recovery elements. Once again, we all think we're doing a great job until we actually start measuring it, and then this is where the truth comes out. So for this cluster at this point in time, the average was about 62% of the elements were being done, and they ranged anywhere from 30 to 80%. This is that same data broken down by hospital in kind of a heat map format, so we can look at different elements of enhanced recovery as listed on the left-hand side of the screen. The different hospitals are the columns, and we can see that there are some hospitals that are doing well in certain elements and other hospitals that are struggling. And we show these data during the learning collaboratives sessions 3, 6, 9, and 12. So 4 times throughout that year, we really talk about these data so that people know who to turn to for help in navigating some of these challenges. We also give them an implementation report card. So it's not just about adhering to the enhanced recovery elements, it's about learning about how they're going about trying to implement these things. And as we learn that, we put together this report card that's really qualitative, very subjective, less objective data, but more subjective interpretation by our study team as to how the local hospital is doing with implementation. And actually, this data, this information has been more helpful than just knowing what their batting average is for a specific enhanced recovery element. So I'm going to wrap up soon. I think I'm out of time already, but nonetheless, I'll finish up in just a second. Enrollment's been slow but steady. We've passed our first Data Safety Monitoring Board meeting. Our first cluster's nearing the end of the implementation, and I would say that most of them are still working on aspects of implementation. This takes longer than a year to get up and running, and that they're really exploring sustainability. How are they going to sustain this work after the learning collaborative sessions end? And the second cluster is really beginning, and I think they're going to benefit tremendously from a lot of the tools and lessons that we've learned from the first cluster. There's a lot of things in our future. We have the clinical outcomes we're looking forward to measuring, the implementation outcomes, and then the effect of those implementation outcomes on the clinical outcomes. I think that's going to be really great to learn about. We have a lot of focus now on this mindfulness and deep breathing aspect of healthcare, which I think has been understudied in the pediatric population. And we're going to continue to refine our implementation tools and make them publicly available as soon as we can, and some of them already are. And then I think that the next steps are to think about where Enrich Us needs to head in terms of not just looking at GI surgery, but looking at other areas as well. And that's really it. If you have any questions, please feel free to grab me after the end of the session, or send me an email, visit our website. And it's just a picture of my family on a hike recently. Thank you.
Good morning. My name is Kyle Rove. I'm a pediatric urologist at the University of Colorado and Children's Hospital Colorado. And I want to talk about our multi-center study in pediatric urology called PURSUE, which stands for Pediatric Urology Recovery After Surgery Endeavor. I have a few disclosures. And similar to Dr. Raval, I'm going to tell our story and how we got to enhanced recovery and the creation of our multi-center study. And then discuss a little bit about the fruits of our labor. So how did we get to enhanced recovery after surgery? It really goes back to how these patients were cared for traditionally. In pediatric urology, bladder reconstruction, which is surgeries like bladder augmentation, creation of catheterizable channels, these patients tended to stay in the hospital, had pretty rough postoperative course. Many of them had ileus after surgery, and these were just challenging patients to take care of. Many of them would be pre-admitted, and there are many centers around the country still doing this, pre-admitting patients, putting them on prolonged clear liquid diet, NG tubes before and after surgery. They're getting varied bowel preps. Patients are getting lots of fluids. Surgeons like their patients wet because they want to make sure that the urine output is good after surgery. And as urologists, we would avoid NSAIDs because we're worried about the urine output as that can be affected by these nonsteroidals. Many of our patients have neurogenic bladder, they have spina bifida, they're felt to be insensate, so we tell the anesthesiology colleagues, don't do a regional, we don't think they need it, they're insensate. And then we wouldn't feed them, which is funny because these patients have neurogenic bowel and they often need assistance in terms of having bowel function, so there's a little bit of a catch-22 there in terms of waiting for spontaneous bowel function. before feeding them. And then they would just stay in the hospital a fair amount of time. I was fortunate to train under one of my mentors, Dr. Duncan Wilcox in Colorado, and over time in his career, he started to question some of the dogma in pediatric urology, how we cared for these patients. And over time had adopted practices that really, we realized, aligned with enhanced recovery after surgery tenets. And so with that, we realized we had already been taking baby steps toward an enhanced recovery protocol. And during my training, we started to see publications coming out in adult urology, the cystectomy literature, showing that enhanced recovery after surgery could be applied in urology patients on the adult side. And we realized, gosh, we're doing stuff that's very similar in pediatrics. Why not try to see if we can apply that in our space? And so we did a pilot study during my training, also small, just looking at a cohort of patients prospectively using the enhanced recovery protocol. And we saw that we were able to bend that length of stay curve down quite a bit for these patients, and importantly, didn't see any change in balancing measures like readmissions, reoperations, or ER visits after surgery. There was always the worry amongst the surgical team that if we're sending these patients home sooner, that they might be bouncing back to the hospital or having unintended consequences, and we did not see that. And importantly, we also saw a decrease in the number of complications per patient. And I think when you look at the ERAS literature as a whole across all specialties, adult or pediatric, this tends to vary quite a bit, but at least within our study, we did see a significant difference and told us that we were onto something. And it really encouraged us to take this to the next level. And when we thought about what that next level might be, in our specialty, these patients are pretty rare. I mean, we only actually had 13 patients prospectively over a 2-year period at our single center who underwent these operations, and we're a pretty high volume center. So we realized that we were gonna have to partner with other centers in order to enroll a large number of patients to really study this and study implementation to show that ERAS works in the pediatric space. And so, Pediatric Urology Recovery After Surgery Endeavor was born. We have fantastic partners at 8 centers across the United States. We really wouldn't be where we're at without the help of all the site PIs who have contributed to our study, along with our anesthesiology college. Each center has basically a lead who works with a lead anesthesiologist, and they have developed and sort of run with ERAS implementation locally in order to make this work and enroll patients. And so this really all started in the fall of 2016. We met, came up with a study design, talked about what outcomes we were interested in, and started recruiting centers. And those who were ready, we set them off to start multidisciplinary meetings and implementation locally at their centers to get ERAS up and running. So our study is a prospective case control study design. We enroll patients prospectively undergoing surgery under the ERAS protocol. We're going to compare these to historical controls. They'll be propensity matched 2 to 1. Our primary outcome is the number of ERAS elements achieved, with secondary outcomes of length of stay, complications, some balancing measures. We also have a patient-reported outcome measure and pain scores and opioid usage. We include patients 4 to 26 years of age. These are patients undergoing lower urinary tract reconstructive procedures, so bladder augmentation, Monty Mitrofanov's, incontinent diversions. Oftentimes these cases are combined with bladder neck reconstructions or bladder neck slings. And then we did come up with some exclusion criteria. These patients, many of these patients have neurogenic bladder and neurogenic bowel. We wanted to make sure that we were not necessarily being adversely affected by patients who had untreated neurogenic bowel. In reality, this is, it's pretty uncommon for us to exclude patients that meet these criteria, just because many of these patients come in and they're already being treated for both conditions simultaneously. And this is the protocol that we designed with our study group, 20 care elements spanning all 3 phases of care that are very similar to the sort of protocols that you'll see in most surgery settings. The challenge, I think, with this was, from a research perspective, defining each protocol objectively so that when we were tracking this from a research perspective, we could actually say objectively whether patients met or did not meet. And that is challenging in some of these things because how do you objectively define euvolemia? How do you objectively define minimization of opioids intraoperatively or postoperatively? Fortunately, with our pilot data, we were able to feed forward some of that and use some benchmarking in order to set some objective criteria so that going forward, we can tell centers objectively whether they're meeting certain criteria or not. As with Dr. Raval, I mean, the IRB regulatory stuff is not to be underestimated. This aspect of this is super challenging when you're dealing with a large multi-center study. We went about IRB approval for this study differently. We had each center individually get an IRB approval, which requires a lot of coordination still, because if there's any change in the master protocol, those changes then have to be fed forward into each of the centers' IRBs and go through their own IRB amendment processes. We executed the data use agreement so that our centers could all share the data with us into a single database, and then we put our study on clinicaltrials.gov for all to see. And we designed the study in sort of two parts. So there's a built-in pilot phase for each of the 8 centers where we document the implementation. We have the centers start enrolling patients and do the first 5 patients on the ERAS protocol. We assess adherence. The neat part about this is there's an external audit committee that comes together at the end of the first 5 patients at each center, and we meet on Zoom, and we talk about the adherence, and we go through areas where they were doing well and what areas they were struggling on, and then basically we learn from each other and we provide feedback. Well, what were the barriers? We talk about ways that we think they might improve certain things, and similar to Dr. Raval, it's been sort of a learning collaborative technique and exercise, and I think we all enjoy those phone calls. We're able to come together and sort of assess our progress and move forward together. And the second part, those 5 pilot patients from each center are then fed forward into the exploratory phase, where we're going to explore the clinical outcomes, look at patient-reported outcomes, and then follow patients out to 1 year. The 1-year follow-up is interesting, and it's really unique to pediatric urology. Many of these patients have neurogenic bladder, spina bifida, and have a VP shunt. In the pediatric urology literature, there's been concerns that changes in bowel prep and management around the VP shunt at the time of surgery with bowel prep might affect the rates of VP shunt infection, which is a pretty serious complication after these sorts of surgeries. And that risk is thought to extend out to 1 year, so we wanted to make sure we were following these patients really closely, looking for those outcomes and events and making sure that we weren't seeing any changes. Our study tracks short-term and long-term complications very closely. We have a long list, a pretty comprehensive list of complications that are assigned a grade, and we're trying to be as inclusive as possible. I think in the long run, when we end up publishing this, it's going to look like we have a high complication rate compared to the literature, but we're trying to be as inclusive as possible, really to make sure that we're not missing anything. But the nice part about being super inclusive in the prospective part of this study is that we're able to actually go back to families as we sign them up for surgery and say, we know exactly what the risk of having some of these complications is after surgery. Many of them are low grade, so fever, nausea, vomiting, and we can tell them exactly what to expect, and that's really helped families better prepare for surgery and give them as much information up front so they're prepared for surgery. And we've started to see some of the fruits of this labor, which has been going on 5 years now. So we were able to publish our design and development paper, which really just outlines the protocol and how we designed this study, along with all the outcomes. These sorts of papers are really, I'd say, challenging to publish because they don't really contain any data, but we felt there's so much information just about how the study itself is designed that we wanted to get this out there so that subsequent publications, we wouldn't necessarily have to take up space, and we could actually focus on the more important clinical outcomes. We've completed a pilot phase for 6 of our centers and tracked sort of how the implementation went. It's amazing when people come to me and they ask for advice on how to implement ERAS. just like with Dr. Raval's study, I mean, it's not to be underestimated how many meetings it takes to really get a team together, to get everyone at a center organized in a way that can make this work. So on average, each of the 6 centers met 7 different meetings with a number of participants. On average, it took 60 days from first meeting to first enrollment of the first patient. And then the pilot duration, again, because these are pretty rare patients, on average took just under a year. But when we tracked sort of how implementation went in terms of documenting implementation, enrolling patients, following up patients, and then assessing adherence during the pilot phase, we were pretty successful across the board. Actually, I'll highlight the last line there. The adherence to the protocol on average with our 6 centers during the pilot phase was 16 out of the 20 elements. Most of the groups did very well. And this is just a graphical sort of illustration of the sort of timeline to implementation and then enrollment of those first 5 patients. You can see all but one center were able to do this under a year. The interesting thing about Center 2 was that they did some combo surgeries with their pediatric colorectal colleagues, and there was some disagreement about the protocol, and so that was a major barrier for their center and really slowed down their implementation and ability to enroll patients. Interestingly, the only reason I think they were able to finish enrollment during the pilot phase was that the surgeon that they disagreed with moved on from their center, so they were able to actually get the protocol out and running. So what have we learned? I mean, so multi-center collaboration is a lot of fun. I mean, obviously we learn a lot within our center, but being able to collaborate with other colleagues and learn about barriers at different centers and in different settings is really, I think, takes it to the next level. We're just basically able to bounce ideas off of each other and I think take stuff into our centers that we can, best practices, we just, no one center is going to have the best way to do it, and you just learn from each other. And we've created a really rich data set from which we're going to be able to answer subsequent questions. And from the quality improvement side, the thing that I've taken away over the last 5 years from enhanced recovery after surgery and our implementation across 8 centers is that the key to success is decreasing variation. That is why ERAS works. And we just see that, and I'll show you some data to support this, but that decrease in variation is really, and from patient to patient, from provider to provider, is really, I think, what minimizes the spectrum of outcomes that patients experience after surgery. And with quality improvement, implementation of ERAS, it's hard and change is hard. And I think having data is key to convincing our anesthesiology colleagues, our surgical colleagues that enhanced recovery works. I think there's a realization from surgeons when they start to undertake these efforts that the peri-op space is more diffuse than we realize, that there are a lot more people that interact with surgical patients around the time of surgery than just the surgeon and the anesthesiologist and the OR nurse. I mean, there are so many other people that we don't sort of take into account, and if you don't, your implementation may not be as successful. And so process mapping, all that stuff, super important, and I think all of our centers and all our surgeons who are participating in this work realize that now. And really, we've just continued to push each center to continue to iterate using PDSA cycles and promoting ERAS locally. Most of our centers now, the site PIs are now their local expert, and they're the go-to person for other surgical specialties who are now coming to them for help in implementing ERAS at their center and expanding to other surgical specialties, and that's really exciting to see. So we're hoping to wrap up our study now. We've enrolled over 150 patients. We're sort of finishing up our final one-year follow-up for our last enrolled patient. We're expecting to report our results out next year, but this really isn't the end. As I mentioned, I mean, this is our super rich data set now that we're going to be able to answer a lot of different questions. We hope to use that to iterate the protocol, slim down our data collection, and to continue to enroll patients so we can study it into the future. And just, this is one slide on decreased variability. So, this is just a a little bit of a run chart from one center for the post-op opioids. And you can see there pre-implementation, the amount of opioids we were giving patients was kind of all over the map. But with some benchmarking and some guidance, and obviously with multimodal strategies for pain control, we were able to tamp down the variation and amount of opioids quite dramatically. And if you, I don't have the other slides here, but if you look at the other protocols, the other elements in the protocol, and you map this out, you see the exact same story repeated across all the different elements of the ERAS pathway, which is really fun to see. And then, recently we actually used our data set to ask a sort of some related questions. One area we've been interested in that I sort of alluded to earlier is that for spina bifida patients for a long time, we weren't doing any regional therapy. And we wanted to dig in and see, gosh, we have this nice data set. Can we answer the question how spina bifida patients in particular do with regional catheters? Historically, we weren't doing any regional therapy, like regional catheter-based analgesia for these patients, and we wanted to see, is there a difference, and do they benefit from the regional in addition to other multimodal strategies? And you can see from the graphs there, when you give these patients regional catheter-based analgesia, their amount of opioids used intraoperatively and postoperatively drops dramatically. And although they may have altered sensation or decreased sensation to light touch, I think these patients still benefit from multimodal regional techniques. And we're hoping to publish this in the near future. The one thing that our surgical colleagues also come to us when they're thinking about implementing enhanced recovery is the amount of time spent by anesthesia doing blocks. Sometimes I think the surgeons can be a little hesitant to give the anesthesiologist in the room a little more time to do this. And when we looked at the numbers for this, the blocks took on average about 25 additional minutes in the operating room, but the total OR time actually didn't change. And with that, I thank you very much, and we'll be happy to take any questions. I also am happy to take any emails with questions, should you have any. Thank you very much.
So we have a couple minutes in our schedule for just a discussion for those two excellent lectures, and so we'll just open it up to the audience for any questions for Dr. Raval or Dr. Kyle here.
So you guys make this look really easy. Can you tell us a little bit about what epiphanies you've had about compliance with the protocol? And if there are hot spots that you've seen where either the surgeons struggle or the patients struggle, and how you've addressed those?
One observation that I've had through our study and our work is that there were both families and providers who would come to us and say, gosh, we weren't able to do the pre-op drink. Or the anesthesiologist would note this and come to me and say, gosh, we can't do the protocol. And this would be repeated across any number of the ERAS elements. And I realized that this was a little bit of it required a little bit of a mindset change in how you talk to families and talk to providers about ERAS. That these are guidelines, they're best practices, but they're not end-all be-all, and they don't have to be applied universally in order to succeed. Our goal is to maximize the number of elements we apply to every patient, but there are many patients who might have, say, CKD and can't get NSAIDs. That's okay, we're gonna do everything else in the pathway. And when you frame it like that for families and providers, I think it really helps sort of change their mindset that patients aren't necessarily falling off the pathway, or we can't necessarily apply ERAS just because we didn't do one thing in the protocol. And that has really helped, I think, move us forward and move through those challenges where we missed something from a process standpoint.
Yeah, I have so many illuminating moments each and every day and week about this entire process. I mean, talk for an hour about the lessons that we've learned because we've taken missteps, and I think that those are powerful, and I think that those are really pragmatic for anyone who's starting out on this adventure. But I mean, I can give you just a couple of examples. Number one, from a logistics standpoint, we have really complicated healthcare systems that we all practice in, and when doing a singular quality improvement project about one element is hard enough in and of itself. Enhanced recovery protocols span the continuum of care, as you've heard both of us talk about, as you are all aware of. And I think you have to have system-level support from your IT infrastructure and building order sets, from your frontline care providers to document things that aren't normally captured in the EMR, right? Did you get up and ambulate or not? There's no flow sheet vital slot for ambulation, right? You have to figure out a way to change our healthcare system to help you capture the things that are actually going to help our patients, not just capture the check boxes and the things that we do day in and day out. So I think that from a pragmatic standpoint, one of the biggest epiphanies I've had is that in your implementation team, you have to have that IT representation, you have to have that nursing representation on the front lines early on to build those things in so that then you can actually have the data and measure it and do it successfully. So that's one. I think that another big epiphany in terms of culture has to do with allowing space for us to change the way that we've been dogmatically practicing for years, right? And it's amazing how powerful the one dissenter can be. You mentioned it about one of the sites that they were not going to be successful until this person left, right? I mean, and that I hear that over and over and over again. There's this one high volume surgeon who just doesn't believe what you're saying, and we're trying, but they keep it's just hard to get. And honestly, if anyone knows the solution to that problem, other than something that would put me in jail, please let me know. But like
Unfortunate car accident by the colorectal.
yeah. So not wishing harm upon anyone, that's a joke. But nonetheless, like it is a reality of how we practice in healthcare. It's changing, but the change is slow. It may require people moving on or retiring or stepping back, or it may require a powerful leader coming in and saying that this needs to happen. And those are really hard discussions, and those are challenging, on numerous levels. Whether it be the way people are financially compensated, it may have to do with the way that practice and referral patterns are within a community or within a hospital system. And so I've had to navigate a lot of those, and those have been challenging to say the least. So there are a lot of obstacles and roadblocks, but I think that some of the things that you've heard both of us mention are that we can learn how to navigate some of those things from each other, and kind of build the momentum towards changing for the positive.
Both of these presentations are phenomenal. I'm sitting here with a ton of questions already. But, having been at Emory and seeing things, how you guys implemented and benefited from that, and now at Vanderbilt, we are trying to build this, from Drew has been carrying a lot of shoulders, and one of the questions I have, I guess, is a very specific one. Having had 18 centers in Enrich Us, and then 8 or 9 centers with your Pursue trial, the data itself, it seems like you have to be able to sell that to your administration to be able to get the support that you need, and that's sort of a lot of the roadblocks we're talking about. When we look at the data sets from all your different centers, have you found any one particular or 2 or 3 that are easier to capture that data? Because I can't imagine that there's variability within each of the centers. I know that you're putting it all together into a central repository, but we have Epic, Tableau, all these other ways of collecting data. When you go to actually put this together, have you found, for those of us who are trying to start this, the data collection process, obviously with a big army of people and having support, but when you don't have that, how can we better understand the data and the collection of the data? And have you found that in any of your centers that any of those particular places are collecting data that makes it easier on the back end?
I mean, I'll be curious what you say, but I mean, don't go too big. I mean, you want enough data to be able to answer the questions of compliance, which is super important to feed back to the teams, because you want to be able to do that sort of PDSA cycle, and you want to show that data to teams to both encourage them that they're doing well in certain areas and show them where they're not doing well, where they can improve. And you can't do that without data. And like you said, Mehul, I mean, ERAS encompasses the entire sort of surgical journey, and there's so many data points that you need to answer the question as to whether you were compliant with the protocol. But you just don't want to go too big. It just becomes too much data to pull out, and it becomes too much to sift through and sort of get down to whether you're compliant. So I mean, I would just caution you on going too big when you're thinking about starting, and go from there.
Yeah, so among our 18 hospitals, we've got every EMR you can imagine. There's one hospital that has a homegrown EMR system. There's one that has Epic. I mean, several have Epic, several have Cerner. Those are the two biggest EMR providers in the United States. And so we've got all represented. The way, I think that you're asking maybe two questions. The way that we've gone about putting together data from all these disparate EMR systems is we've chosen to use a REDCap data collection tool. It does mean that we have to have data abstractors fill that data in, and that is for this study, right? It's not necessarily a long-term sustainable system. That's not what I'm talking about. So I think that to answer your question, the way that we do it for the study is different than the way I think it's going to be sustainable for those individual hospitals in the long run. The individual hospitals in the long run are going to have to modify their local EMR systems to collect the clinically meaningful data that we need. And that is where partnering with your chief information officer, your chief IT officers is important. Getting in the workflow to where it's not an extra burden, it's actually part of the intake forms or part of daily vital checks or part of whatever. Those types of workflows need to happen. But in general, you know, I think those two systems are done in parallel. We are using the REDCap to uniformly collect things across the board. If people like the elements that we're collecting, if they like being able to monitor the adherence to the level that we're monitoring it, then they need to, in the long term, spend time building that for sustainability locally, because the REDCap will go away when the study is over.
Yeah, I would agree with that. I mean, we're also using REDCap for our study, and from a sustainability standpoint, it's just for quality improvement outside of a study. I think it's probably more than you want or need, and may not be sustainable. The second thing is, I agree 100%. The holy grail, I think, of sort of implementation is to be able to modify the entire process, including the data collection, you know, as it goes into the EMR, to align with the protocol itself and what care elements you think are necessary. You know, pre-op nurses at our institution, for example, are trained in how to, you will document when the MPO time was, so that when they last ate or drank something, but they wouldn't necessarily have a place to document what the pre-op carbohydrate drink. So we were able to work with our IT folks and create a flow sheet in the EMR for them to document that, and it comes up specifically when the patient is marked as having the ERAS protocol. And I think doing that for each care element in a way that makes sense so that you can track compliance long-term is really important. But it's really hard to do because you have to work with a whole other part of the hospital, the informatics side of things, and that's not always easy and doesn't happen overnight.
Is it my turn?
Go ahead.
I am a mere adult surgeon, so I apologize in advance for taking care of vascular patients rather than kids. But I'm at UNC, and we've got 5 different pediatric ERAS pathways, and unfortunately, none of my pediatric colleagues could be here with me, so I'm listening in, and I appreciate the learning. All of you are clearly awesome, hardworking people, and instead of focusing on implementation struggles and length of stay reductions, which are always the first steps and you always need to struggle through it, and I really hope that we can amplify what you're saying to make it easier for everybody else. But what are your visions for the next 5 to 10 years once this becomes standard? Do you have qualitative scientists who you're working with to help you figure out better implementation strategies? Do you have PROs that you want to work in? Do you have patient stakeholder groups to figure out which of the bits are actually the most important? We assume it's getting out of the hospital pain-free, but I'm just a dumb adult. What do I know? The kids are leading us, right? So mainly just kind of pie in the sky, like what do you think about for your next R?
Yeah, so it's all of the above. So I didn't get a chance to really get into it, but we have an entire qualitative team that records every one of those learning collaborative sessions that I described that happen 12 times for each cluster. We do focus groups with patient stakeholders as well as with the care providers and kind of hear their voices about the things that they're struggling with the most and the things that have been the most helpful for them as they've navigated those struggles. And we're qualitatively assessing that continuously during the study, and obviously at the end we'll hopefully have the ideal implementation toolkit, right? We've got one that we've started with and we're modifying it actively, but it's informed by a lot of those stakeholders through those qualitative interviews and focus groups. We're collecting patient-reported outcomes, so we have a battery of PROMIS tools that we're collecting once preoperatively, and then postoperative day 2, and then postoperative 2 weeks to 4 weeks out, just to see how things were going, not just with pain control, but rather with quality of life assessments for global assessments, but also anxiety and physical activity and all those other domains that have been surveys that have been validated by the PROMIS group. And so I'm eager to see what those look like, because just because we may not demonstrate a length of stay difference doesn't mean that there are not other clinically meaningful outcomes beyond opioid use, beyond total fluids, all the other clinically oriented things that we think about. There probably are going to be some, I hope that there's going to be some benefits that our patients are reporting from the enhanced recovery experience. Fast forwarding 5 to 10 years, I really think that this is going to be standard of care. We're not going to be talking about struggles of implementing some of these things that are right now seem insurmountable, but are really actually normal. And part of that will be because I think that there is a cadre of general surgery, urologic, anesthesia-related trainees that are coming up through health systems like yours and like mine and like theirs, where this is just normal. And why would you not do these things? Or why would you leave an NG tube in for 4 days? Like they're just going to question the dogma of surgical history. And as they become practicing physicians, they're just going to deliver that care in an enhanced recovery way without even realizing it's enhanced recovery.
I'll make one comment about kind of the 5 to 10 year plan. I had the opportunity to speak with Dr. Kellett a couple years ago, and he made this statement to a group of us where he said, his vision in the next 5 to 10 years is we take the E out of ERAS, and this becomes a standard way that we take care of surgical patients. And so I think, what Dr. Raval said is very telling. I had a moment of zen, if you will, a couple months ago, where one of the orthopedic surgical trainees that left our institution went to another institution that wasn't doing anything like this, and he said, "This is not the way we care for patients. This is what I saw at Vanderbilt, and then this is what we need to do." And so the basic elements of multimodal and all the other things that we look at, and so he went and he basically started that at his institution. And so we are. A lot of us work in training institutions where, they're seeing what we're doing, they're looking at the struggles that we're going through, and eventually we're going to be able to take that E out of ERAS, which I think is the big goal here.
Just to add to the answer to her question is, after about 5 years of using an enhanced recovery protocol at our institution, and labeling all the patients so that the anesthesia team and the perioperative team knew that they were coming in and they were drinking carbohydrate drinks in the car on the way to the hospital. Then on March 1st, a year ago, the 43,000 sedations and anesthetics that occurred in our hospital became NPO for clear liquids for 2 hours for all those. So the ancient thing where you don't get to eat or drink anything. So that's kind of the vision, Drew, right? Is that we want all the patients to be getting that as opposed to just the people that have ERAS written next to their name. Sorry, didn't mean to.
No, well, I'm just hogging the mic at this point because I have another follow-up question. Because I completely hear you, right? And especially in the adult space, you know, vascular is very new to ERAS, and so I'm still having the same struggles that you're having with like the pediatric orthopedic surgeons, for instance. I feel that. However, the colorectal folks have been doing this already for almost a decade, and it is just standard care in that adult population. And so I think that there's a lot there. But one thing that I've noticed at my place is with the nursing staff, just revolving door, and the fact that now the majority of the nurses on the colorectal floor at UNC, where it is just standard of care, don't actually know what ERAS is, and a lot of the little value-add things that they do have gone away. And I think as surgeons and anesthesiologists in that kind of hospitalization, intraoperative, and like, you know, pre-op prep for surgery phase, you can get a lot of dissemination and spread. And as we're training all of these folks through our training programs, you are going to start to have more and more of these Zen moments. But there's just so many more nurses, and nurses are so much more mobile, and they're clearly at least 50% of the driving force of all of these process measures. And so I wonder, is this something that we need to be getting in front of nursing schools about, or when nurses are getting their med-surg rotations? How do we make this standard of nursing care also? And I would presume that pediatric nursing might be like a nice pilot population, because at least they're somewhat specialized into a smaller population. What are your thoughts on that?
I mean, that's a great observation, and I 100% have. I was, in fact, just thinking this morning, you know, it's been 2 years since I met with our floor nurses and gave a talk on ERAS. I need to do it again, because they change frequently, and even those I speak to, you know, half of them are on shift, some are off shift, and so this group I end up speaking to ends up just being a small core group of nurses. There's probably at least 3 or 4 times that many who aren't able to even make the session. And I think we just have to continue the education, and I think it's a great opportunity if we could partner with them and really find formal ways to integrate them and give them ways that they can be sort of part of the protocol, and make sure that we're not taking tools away from them, but giving them, you know, opportunities to participate. I mean, one thing I talk about with our floor nurses, for instance, is non-opioid pain management strategies. And I think pediatric nurses do this a lot already, but really emphasizing that it's not just pain medicine, it's giving them a heating pad, a cooling pad, teaching them how to breathe, walking around the floor with them. There's so many other things that they can do that are non-pharmacologic, that's right in their wheelhouse, that I think we can give them those tool sets if we develop them and continue the education, which is key. And it's something I still think we struggle with, at least at our 8 centers, doing well. I think we could do a lot better.
Yeah, I think there's, I'm just going to, you know, echo what both of you guys have mentioned, which is that there is high turnover. It is a powerful ally to have, and I would argue that you know, just as important, I mean, as the nurses, is actually engaging the patients and their families to be advocates, because they will then in turn say, wait a second, I watched videos that said I'm supposed to eat a cheeseburger right now, like what's going on? But nonetheless, I mean, I think you're right. Engaging with those groups, whether it be nursing or the families and the patients themselves, is such a big part of success of enhanced recovery. I'm going to give you 3 tangibles of how we have gone about making sure that we're keeping our nursing force educated. We do quarterly updates where we go and talk about enhanced recovery on a quarterly basis at various nursing education forums. So sometimes it's during daytime shift or evening shift or night shift. But we do this quarterly so that we hope we're hitting the shifts at least once a year. It's hard, it's a lot of work, and it's not always me that goes. Sometimes it's one of our nurse practitioners or other people that are involved in the enhanced recovery process. And so we've created kind of a standardized slide deck that we use over and over and over again to hit this group specifically. The second tangible idea is to actually include the nurses on your ward rounds. Taking a moment to chasing down the bedside nurses, and we're rounding on your patient, and then talking through enhanced recovery for that specific patient on that specific postoperative day just really helps solidify the protocols in everyone's minds, not just for the nurse, but for the residents that are coming through and for the families to hear it out loud again and so on and so forth. And so doing those team-based rounds has been really helpful for helping orient new nurses to the processes. And then the third part, I think that you hit on something really fantastic, and that is bringing it into like the education of like schools of nursing or just looking at it from a bigger perspective. What we've done is encourage people to have nursing representation in their implementation teams, and then those folks are usually senior and respected people within the nursing community, and they then take that information back out to their respective teams, whether it be in the perioperative nursing period or whether it be in the postoperative floor nursing world, but really making sure that they're a part of this curriculum, so to say, for the monthly learning collaborative sessions and for the local implementation team meetings is so important. There's way more nurses that touch the patient along the continuum of care. It's not just like the pre-op nurse that's checking them in and the post-op nurse that's taking care of them on post-op day 0. There's so many other layers of nursing there, from PACU to post-discharge clinic nurses, et cetera. There's a lot of folks to include at the table.
Yeah, and we've had to tailor our education for each one of those groups. Our clinic nurses do a very different job than the pre-op nurse, than the PACU nurse, than the floor nurse. And so we've had to sort of come up with slide decks and sort of tailor the education for each one of those groups and really kind of allow them to flourish in their roles.
It's a fantastic discussion. Thank you both for great lectures. In the interest of time, I think we're going to go ahead and get started with our next lectures here. So we'll have Dr. Brockel.
To any of you, can you hear me? That may be veterans or have family members that are veterans. We thank you for all you do. So I'm going to spend hopefully the next 9 or 10 minutes or so talking about unique, or maybe not so unique, preoperative pediatric enhanced recovery considerations. I don't have anything to disclose. And this is a figure from an article that a lot of you have probably seen. It's a really nice review published by some of our adult colleagues who are at this meeting about enhanced recovery, published a couple years ago in JAMA Surgery. And so what I'm going to point out here is what a lot of you know that we're doing in terms of preoperative elements for our adult patients and how those things relate to what we're doing or not doing for pediatric patients. And at our hospital, I work closely with Dr. Rove. We have developed several enhanced recovery protocols for various different surgeries and surgical subspecialists, but our most robust experience is with urology, which is what I'll primarily focus on today. So these are the 9 elements that they focus on in that figure. So the first is pre-admission nutritional support, and this isn't something that we include routinely in our pre-op or in our pediatric preoperative optimization, but I think after listening to the abstracts yesterday, it's certainly something that we've been kind of inspired to work on more. So it's not included routinely right now, but I think this is an area for improvement. Thankfully, cessation of smoking and control of alcohol intake aren't generally applicable to our pediatric patients, but like Dr. Franklin mentioned in his talk, there's a lot of overlap. In the next 6 items, there's really nice overlap between adults and children, and so this is what we'll focus on for the next several minutes: medical optimization, preoperative information counseling, selective bowel preparation, which we heard about from both of our surgeons this morning, carbohydrate drinks prior to surgery and minimization or avoidance of NPO times, and then postoperative nausea and vomiting prophylaxis. So how we do medical optimization and preoperative information at our hospital is through our Enhanced Recovery Preoperative Clinic. This is a monthly clinic that we have. It's multidisciplinary. Our patients meet with an anesthesiologist, a surgeon, a psychologist, a nurse, and a research coordinator. And not intentionally, but it is telehealth. We started it kind of as the pandemic was ramping up, and this was our best option at the time. And it ended up being so successful that we've chosen to stick with it. It's very nice for all of the providers. We have a meeting at the beginning, a meeting at the end, and we can chat during and in between patients. And it's very convenient for the families too. They can save a trip to the hospital. And what we focus on in this clinic is medical optimization, so making sure that patients aren't necessarily low risk for surgery, but that they're as low risk as there can be, that we've really done the best that we can to prepare them for surgery. And then this is where we give our preoperative information. This is where they receive their counseling. We know that a lot of preoperative anxiety stems from what patients don't know rather than what they do. So this is our chance to really to educate them about surgery from a medical standpoint, and then our psychologist works with them too, identifying family stressors, things that are going to be difficult about having a hospitalized child, how she can work with them and connect them with the right resources, and then managing expectations. A lot of our patients have had surgery before, and things looked different when they had surgery 5 or 10 years ago. So really explaining to them what to expect, but also what we're going to expect from them as far as pain management after surgery, mobilization, feeding, and so on. And we know that patients remember only a small portion of what we tell them, and a significant portion of that small portion is remembered incorrectly. So we send them home with information too, and this is the one of several handouts that we have. It's very nice. And Dr. Rove developed this. It has kind of the key points of what we talked about. It has the ERAS Society website for families that are interested in learning more about what we're doing, and it has phone numbers to get in touch with us if they think of anything after they left their visit that they want to discuss or any questions that they want to have answered. So as far as selective bowel preparation, I'm not going to get into this too much. We've heard about this, that applying bowel preparation to all of our patients is not what we're doing anymore, that it doesn't have the benefits for everyone that we once thought that it may have. So at least for our urologic patients that are undergoing surgery that involve a bowel anastomosis, we don't use a bowel preparation. In terms of preoperative carbohydrates and minimizing fasting, so we know that the ASA fasting guidelines are 2 hours prior to procedures for children. And recently, the European Society for Pediatric Anesthesia reduced their fasting requirements from 2 hours to 1 hour, and this change was endorsed by the European Society of Anesthesiologists. So what we know is reducing fasting in children reduces thirst and hunger and discomfort, as we would expect, reduces fluid deficits, reduces electrolyte abnormalities. It reduces intraoperative fluid requirements, allowing us to use goal-directed or volume-directed fluid resuscitation, and it does all of these things without increasing the aspiration risks at all. So we know that aspiration in children is rare, and morbidity and mortality associated with these aspiration events is even rarer. And there was actually recently published a paper out of Sweden. They removed their clear fluid fasting requirements altogether. Children can drink right up until they're taken back to the operating room. They've had this in place for over 10,000 patients and actually didn't see any increases in aspiration or morbidity associated with aspiration. So this is certainly where we're headed. I think for a long time we focused on long fasting and minimizing aspiration, thinking that this was the best, and also really focusing on getting patients into the operating room on time. And it turns out we didn't need to do that, and it wasn't as helpful as we thought it might have been. So a couple things that we also had hoped for in children was that maybe reducing fasting would reduce post-induction hypotension in children. So this was recently published in Anesthesiology. It was a very hotly discussed paper what this group concluded was that longer durations of clear fluid fasting in children were associated with an increased risk of post-induction low blood pressure during surgical prep, although this association was non-linear. So this data is weak. The association was not strong. There was a lot of criticism of this paper because of this nonlinear association, but also because we don't have a clear definition of hypotension in children. You know, yesterday during the abstract, someone talked about we always maintain our MAP at 65, but we don't have that. We don't really know what hypotension is in children, and we also don't know, you know, in a child who's having a relatively low blood pressure, at what point does that become clinically significant? And so even if this was statistically significant, which it sort of was, is it actually clinically significant? We don't really know. So there were some letters to the authors, there were some responses from the authors, and really I think the jury is still out, so to speak, on this topic. The other thing that we have speculated and I think hoped for, those of us kind of advocating for reducing fasting times, was that maybe when we're doing these mask inductions in children, these reduced fasting times are actually associated with easier IV placement, and it turns out that they're actually not. So this group, there's a lot of overlap in the authors between the previous article and this one. What they found was that fasting time was not associated with multiple IV insertion attempts. There were other factors that were more strongly associated, things like patient age and ethnicity, time of day of surgery, and ASA physical status. So not necessarily the benefits that we thought we might see in terms of blood pressure and volume status impacting IV placement, but we still do feel that there is a benefit for children in reducing fasting and even in taking this a step farther and administering these preoperative carbohydrate drinks, whichever drink this may be. The adult data for this is very strong. We know that the catabolic response to fasting and surgery is attenuated, and there's an improvement in well-being, a reduction in insulin resistance, and there are some studies that even have found an association with a reduction in length of stay. And so for these reasons, this is what we're doing, minimizing fasting according to ASA guidelines, but we're also administering carbohydrate drinks. So children over 1 year receive either Clear Fast, or if they don't have that, they can have Gatorade. 6 months to 1 year, they're drinking Pedialyte prior to surgery, and then children under 6 months, we're just doing our standard fasting, which is the 6 hours for formula and the 4 hours for breast milk. Along with their handouts that they receive at their visits, they get instructions for diet, and then instructions for when and how much of these drinks they should have. And then lastly, postoperative nausea and vomiting prophylaxis. I know Dr. Raval mentioned that some of the centers in his study didn't do that well with this. So we know that one medication is good. We know that 2 medications are better, that these medications work synergistically. So we kind of have this information everywhere for our ERAS patients. It's hard to miss. It's in the electronic medical record, which is here in the operating room, what they're looking at the computer. It's in our timeout. We have ERAS-specific timeouts where we talk about what we need to do and at what time points. And then we have these quick references on all of our drug carts, our anesthesia carts, kind of step-by-step, the quick and easy, what should I be doing and when. And with this, we've been able to achieve really good compliance with the postoperative nausea and vomiting medications, as well as most of the other elements. So with that, I'll hand off to Dr. Franklin. Thank you, guys.
Alrighty, well, thank you. Let me get my slides. Here we go. All right, well, thank you all for this fantastic discussion that we've had. Hopefully we'll have some additional time to start that discussion again, which I think is the most healthy part of any of these discussions on ERAS. So I'm going to talk about intraoperative and postoperative considerations for pediatric ERAS. I'm going to combine both of those lectures into one lecture and kind of build upon what Dr. Raval, Rove, and Brockel have talked about already. So I have no financial disclosures. This is where I work. This is Nashville, Tennessee, which is most widely known for its country music scene and, of course, its hot chicken. Nashville hot chicken has really taken over the whole world. I was actually doing a conference in Canada a few years ago, and we went to a small town in Jasper, which is in Alberta. And we stopped and we decided to have lunch at a restaurant, and number one on the top of that menu was Nashville hot chicken. And so small town in Canada was serving Nashville hot chicken, and that's how you know you've really made it as a city. This is where I work. My office is right here on the 3rd floor of that central tower there in our Rascal Flats Operating Theater. That's really what it's called. I believe Miranda Lambert's office is right above mine, as well as Carrie Tucker and everyone else who frequents our children's hospital. We are an independent pain service, very different from other ERAS, pediatric ERAS programs across the country. Our ERAS program did grow from our pediatric pain service, both our inpatient and outpatient arms. I know a lot of you have trouble at your institutions getting anesthesia involved and interested and energized for ERAS, and so we were kind of working in the opposite way, where our pediatric pain service was energized, and we're looking to energize our surgeons, which we've accomplished over the past few years. We have several ERAS pathways here. We started out with the low-hanging fruit that I talked about before, which was our complex hip surgery pathway. We moved on to pectus. We have sports surgery, all of our ACL reconstructions, shoulder reconstructions. We started out with idiopathic scoliosis, moved on to neuromuscular, and then we've most recently added on urological as well as colorectal surgery. So I'm going to come back to this fantastic graphic that I showed you guys earlier, because I do think that this drives everything that I think about. And anytime I think about ERAS, I always go back to this graphic because it's so simple, but it's so elegant. And so all the elements that you see here are simple, right? And so we talk about no prolonged fasting. All of those things are very simple in and of themselves. It's hard to implement, of course, but together there's just fantastic synergy. And so this is true for pediatrics as well. I consider these the 21 elements of pediatric ERAS that we try to implement in all of our ERAS pathways as much as possible. In my opinion, and in our experience over the past 3 to 4 years of using pediatric ERAS, if I was going to pick 8 elements out of those 21, I feel like these 8 that I have listed here are probably the most powerful. And so having a standardized anesthetic protocol, prevention of nausea and vomiting, using a minimally invasive technique, if at all possible, maintaining euvolemia, and then multimodal analgesia, early mobilization, early enteral feeding, and audit of outcomes. And so I'm going to spend one slide talking about the first 4, and then I'm actually going to spend quite a bit of time talking about the last 4, which I think are probably the most powerful. So when we talk about a standardized anesthesia plan, the key is to choose your anesthesia champions first. And so it's pretty daunting to roll out something like a ketamine infusion or lidocaine or gabapentin or all of those elements that anesthesia providers, anesthesiologists, CRNAs really need to own to an entire division or entire department. And so the way that we did this is, again, it grew from our pain service. And so our pain service anesthesiologists are actually what we call regional anesthesiologists in the OR. And so they're the ones that initially took over all of our ERAS cases. And so, when they were talking about ERAS, those anesthesia folks that were on our pain service that have already, drank the Kool-Aid that Franklin was preaching, they were already believers, and so they took this to the OR, and so they were the original ones that were doing these cases. And so when their colleagues saw what they were doing, they were seeing their outcomes, they're seeing, Johnny and Susie in the recovery room sitting up and drinking Sprite immediately, as opposed to those other patients that were flat and asleep for the next 2 days. And so that stuff sells itself. Prevention of nausea and vomiting. If you look at those 21 elements and you focus specifically on the intraoperative and postoperative, nausea and vomiting affects everything. And so nausea and vomiting, if you've got an NG tube that goes back in, if a child's NPO for a long period of time, they're not going to get out of bed, they're not going to move their diet along, they're going to stay in the hospital longer. And so that's why I think nausea and vomiting and very aggressive prevention of nausea and vomiting is a huge factor in pediatric ERAS. And so again, that was the first thing that we've noticed when we started our complex hip surgery ERAS pathway, was the elimination of nausea and vomiting, and that pushed everything else forward. And so when we first saw these patients and were thinking about that low-hanging fruit, we would go in and round on these patients, and they had the classic kind of wet rag on their forehead the next morning. And so because they were, nauseated all night, were getting opioids all night, when we started ERAS, that wet rag was gone. They were already dressed and ready to do physical therapy at 8:30 in the morning. And so that was something that was super important for us to try to control. Minimally invasive surgery paves the way for all of the other things. And so there are certain surgical procedures that are not amenable to minimally invasive, but if you do have the opportunity to encourage your surgeons or have a cohort of surgeons that do minimally invasive surgery techniques, that again drives everything else. And so they have less pain, they have less nausea, they're ready to ambulate, they're ready to take diet early. And so all of those things are super important as well. And then we talked about euvolemia a little bit. And so the reason that, anesthesiologists give lots of fluid is because we're worried about blood pressure, we're worried about heart rate, we're worried about urine output. And so when I talk about approaching euvolemia to our colleagues from multiple different angles, we talk about getting that clear liquid diet in a couple hours before surgery. We talk about early enteral take of clear liquids. And so those are two angles that you can approach this from. And then really modifying our anesthesia technique where maybe we don't need to have such a depth of anesthesia where this bottoms out our blood pressure. So thinking very critical about our depth of anesthesia is also important. And then the last thing that we've done is, especially for our scoliosis patients that are on the ERAS pathway, instead of flooding those patients with fluids, we standardly use a phenylephrine infusion to gently boost that blood pressure as opposed to giving them a whole lot of fluid to boost that blood pressure. And of course that is part of our ERAS element that I think is very important, is maintaining that euvolemic period throughout the perioperative space. So I'm going to spend a little bit of time talking about multimodal analgesia, and we're going to get down into the details of this because I think this is really where pediatrics is different, all the milligrams per kilogram and all of those things that are important for us when we're talking about opioid reduction and multimodal analgesia. So when we talk about multimodal analgesia, this is the way that I think about things. You can either break it down into regional anesthesia, where I can spend the next 2 hours talking about all the blocks and catheters and everything. And we can also talk about all these adjuncts that we have listed here, your anti-inflammatories, acetaminophen. We've all seen this before, IV lidocaine, muscle relaxants. So I do really feel like intravenous lidocaine is the fountain of youth, or the holy grail, if you will, of ERAS. And so when we started using IV lidocaine for our spine patients and our hip patients and even our colorectal patients, it has really transformed these patients. And so we started doing a few of those patients just starting IV lidocaine, and that in and of itself really made a huge difference for our pediatric population. Obviously it produces analgesia, it prevents hyperalgesia, potent anti-inflammatory properties, all the things that you see listed here. And the things that I've listed here in yellow are actually spelled out clearly in some pediatric literature as well, by reducing opioid consumption, reducing that nausea and vomiting, which can tank everything else in your ERAS pathway. And again, it can shorten your hospital length of stay. So how do we do this? This is what we do in our pediatric ERAS pathways, is we do our lidocaine bolus of 1 milligram per kilogram up to 100 milligrams on induction. And then for children that are larger than 60 kilograms, we do 2 milligrams per minute, which is really what our adult colleagues do as well. And then for children under 60 kilograms, we do 33 mics per kilogram per minute, as you see listed there. Now, there are a lot of things to think about when you are going to include IV lidocaine into your strategy here. Do you use it only in the operating room? Do you continue that in the recovery room? Do you continue that on the floor? Do you continue that in the ICU? All of those are questions that you have to answer before you're able to include IV lidocaine into your ERAS pathway here. Now, one of the things that was challenging for us and continues to be challenging for us at Vanderbilt is the chair of our P&T committee happens to be an electrophysiologist. And so the surgeons and anesthesiologists that are here in this room, we use lidocaine all the time. We inject it into humans. We inject it into the epidural space. We put in spinals. We do all these things. But if you have an electrophysiologist, he thinks about lidocaine very differently. And so we actually went to the P&T committee to try to get approval for IV lidocaine in the floor, and it's been turned down at least twice. And so for us, we just use it in the operating room and we immediately shut it off because our P&T committee can't really regulate what we do in the operating room, much to his chagrin. So just like Yoda says, for acetaminophen and NSAIDs, use them you must, okay? So if you're going to choose two things as far as multimodal analgesia, just use acetaminophen and NSAIDs. There are very few contraindications to using these two agents in your ERAS pathway. And so definitely incorporate them into your pediatric ERAS. So how do we do this? So there's always this debate about intravenous acetaminophen. And so I get an email every 6 months from our pharmacy chair, which says that you and your pain team and your anesthesia team, you're using way too much intravenous acetaminophen. And what I do is I actually send them 2 papers that shows that using intravenous acetaminophen can actually, over the course of that hospital stay for children, reduce total costs. And so if you're getting patients out of the PACU quicker, that lowers your nursing cost, it lowers your facility cost. If you're getting patients out the door and discharged a day earlier, all of those things reduce costs. And so if you guys have trouble with IV lidocaine at your centers, you have to think about that everybody thinks about their own cost in their own silos. And so they look at their bottom line, and the pharmacy budget says your IV lidocaine, or your IV acetaminophen usage for that month is exceedingly high. But what you want to remind them and kind of educate those folks that are pushing back on your usage is that it can actually lower the aggregate costs of that patient throughout their stay in the hospital. And so I've gained a little bit of traction, but every now and then I do get that email, and we have to have that discussion again. I feel like intravenous acetaminophen for kids is much more effective than oral acetaminophen because a lot of times what our anesthesia colleagues do is if they do get preoperative acetaminophen, they may actually put an OG tube or an NG tube in and basically suck that right back out unless you tell them specifically not to do it. There's a lot of question about absorption of enteral acetaminophen under anesthesia. And so it's unclear to me if you reach a therapeutic level by using oral acetaminophen. That hasn't been studied very well in children. I think that the younger that a child is, your bioavailability for oral acetaminophen is pretty high, but for adolescents and teenagers under anesthesia, it's hard for me to understand whether they actually reach a therapeutic level. And so we use intravenous acetaminophen for most of our ERAS pathways. As far as oral acetaminophen, these are the dosages that you see right here. We don't use rectal acetaminophen anymore. Again, bioavailability from the rectal route, unless you're under the age of about 3 months, is extremely wild. It's all over the place. And so you can have very high spikes in your plasma levels of rectal acetaminophen absorption, or you can have very poor. And so overall, from a pediatric anesthesia and pediatric caretaker policy in general, we're avoiding rectal acetaminophen, so we're either doing oral or we're doing intravenous. NSAIDs, we use ketorolac and ibuprofen very commonly. I've gone to meloxicam PO for a lot of our ERAS pathways as well, and so meloxicam, which goes by the trade name of Mobic, works very well for kids. And so these are the dosing parameters that we use for kids under the age of 50 kilograms and over. The nice thing about meloxicam is even though the manufacturer stopped the production of the solution of meloxicam, the tablet in and of itself is extremely small. Okay, it's about 1/4 the size of your thumbnail, and if you break it down in half, it's even smaller. And the nice thing for us in Tennessee is our Tennessee Medicaid actually covers that, and so it's extremely cheap. And so something to consider if you're trying to use something that's more expensive, like celecoxib or one of those other selective COX-2 inhibitors. They may not actually be able to afford that or have insurance cover that. Meloxicam is very cheap. So as far as gabapentinoids, these are the dosing parameters for gabapentin that you see right here. There's a lot of split evidence in the literature for pediatrics as well as adults on when to start gabapentin, whether gabapentin is truly effective. Do we just do a single dose? Is that going to be effective, or do you have to continue it? Who writes for these prescriptions? How long do you do all of these things? And this is something that if you're going to start gabapentin, you have to spell out very clearly. And so specifically what we do is we have one spine surgeon who likes to start his patients on gabapentin preoperatively. And so one of the safety issues that we had was the nurse actually gave an additional dose of gabapentin to that child, even though she had already had that the morning of surgery. Not a huge deal, but it is something for us to be careful of, and so we included that in our ERAS pathways. Don't give gabapentin unless it was given, if it's already been given. And then you have to clearly spell out who is going to write for the gabapentin. Is it the surgery resident? Is it going to be the NP? Is it going to be your pain service? And who's going to manage that? And then for how long? And so for some of our populations, we actually continue the gabapentin for 2 weeks after surgery. For our pectus population, we actually have it for a full month. And then for scoliosis, we do it for 6 weeks. And then we found for our hip population that when they came back in for their 6-week visit, that they were still having some nagging pain at that visit. And so in our PDSA cycle, we said, why don't we continue this for 8 weeks, 2 months after surgery, and that cleared that up. And so those patients were not complaining about pain at that 6-week follow-up visit. And so that's why, again, why those PDSA cycles are super important to catch those issues postoperatively. Ketamine, these are the dosing parameters that we use here. Again, they're very common to a lot of our ERAS pathways. I do feel like it's effective, and those same things that we talked about for IV lidocaine, you have to sort out with your own institution about how long you can continue that ketamine. And again, ketamine can be very useful as far as multimodal analgesia. Some more practical pearls about starting multimodal regimens. You want to start with the basic agents, okay? So if you follow what Yoda, said, just start with acetaminophen and an NSAID, okay? If you're going to build a multimodal platform, start very basic. If you start with the high-level agents, with what I consider IV lidocaine or ketamine, you may run into some more issues. And so if you're going to start a program at your institution, start very basic with your multimodal agents, and then start building as your institution gains traction and you start to get some early wins. You want to track the data and perform PDSA evaluations like we talked about, and then you want to engage and educate the family on why they're getting so many medications. And so, if patients are used to just getting one opioid as their pain medication after surgery, they may be concerned that they're getting lots of pain medications, and so that's something that we address early and we address often with family members is, why is Johnny and Susie getting so much pain medication? And so you do have to explain that concept of an adjunct very carefully to patients and families. And again, these are the important unanswered questions. Again, starting preoperatively, who prescribes these? All of these things are things that you have to work out before you launch your first ERAS patient. So I come from Georgia, and so I call this pecan pie. A lot of you folks that are on the West Coast may know this as a pecan pie. I feel like regional anesthesia is a component of your ERAS pathway. It's not the most important part of your analgesic pathway. And so if you look at all of the pediatric ERAS literature where they say, should I add regional anesthesia? Should I not add regional anesthesia? They, again, should not think of regional anesthesia as the end-all, be-all for your anesthesia or analgesia plan. I think it can be an important component, but it's just that. It's a component. It's a piece of the pie. It's not the whole pie itself. So when we do regional anesthesia, what are we talking about? Tap blocks, rectus sheath blocks, erector spinae. All of these things have been described very well in adult ERAS pathways, and they do have some efficacy in pediatrics as well. Probably tap blocks and rectus sheath blocks have been the fascial plane blocks that are probably the most prevalent in pediatric ERAS pathways. When we included them in our own ERAS regimens, we found that they tended to be pretty opioid sparing. One of the things that you have to talk about when you're doing these fascial plane blocks and these truncal blocks is when do you do it? And so do you do it at the start of the case? Do you do it at the end of the case? We did both, okay? And so when we started our colorectal pathway, actually our urologic pathway, we started to do these tap blocks up front, and then we did, 5 or 6 at the end, and we just looked at opioid consumption, and we found that if we did the tap blocks at the start of the case, they received less opioid intraoperatively, and they actually received less opioid postoperatively too. And so we chose as an institution to do those tap blocks prior to incision as opposed to at the completion of surgery. So let's talk about early mobilization a little bit. Why do we do it? It reduces postoperative ileus. If children are getting up and walking, they have a better appetite. They have better patient satisfaction. Venous thromboembolism isn't a huge deal for pediatrics, but it is an issue for older patients, particularly ones with ulcerative colitis or Crohn's. That's something that we track very carefully. It does reduce your length of stay. How do you do this? And so you want to set these expectations preoperatively. And so you want to educate those family members, and if you have an older child, an adolescent, or a teen, old school thinking about surgery is if we cut you open, we need you to lay in bed for 3 days and not move. That obviously has changed now. That's not anything new to anyone here in the audience, but that's how some parents may think of their kid, is they don't want Johnny to move because he's healing. Okay, so we have to flip that on its head and say we want Johnny out of bed as soon as possible. Now, I have a son at home that we only allow him to play video games on the weekends. And so if we allowed him to play video games on Friday, he would basically sit in his room from Friday until Monday morning and never leave. And so a lot of times in children's hospitals, we actually have a lot of entertainment options in the room. And if you're allowed to play Minecraft in your room after surgery, why in the world would you leave and go for a walk, right? So set times where you can play video games. And so you can have an hour, set up a reward chart. Say if you walk the hall twice, you get to play Minecraft for an hour. And your child life specialists or charts and graphs, all of those things can be really good with gold stars, silver stars, all those things that kids like to do. So early enteral feeding, why? You're reducing your postoperative ileus, reduce bacterial translocation. Specifically, how do we do this, okay? So how do you do this for kids? One of the things that's super important for pediatric ERAS is you want to try to reduce that fog of war, as I call it. And so a lot of times the length of stay is directly tied in because we didn't really understand what we needed to do for that patient when they got there, okay? So you want to know exactly what their feeds are. You want to know, if they're able to take pills or liquid medications. You want to try to reduce that fog of war when you go in and actually have that patient in the hospital. These are all things that you can clear up preoperatively here. And so I'll tell you a story about gabapentin. Of our very first ERAS patient, that child got to the hospital. Everyone was so encouraged. We're going to launch ERAS. We're going to do great things for our kids. The kid got there, and the nurse wanted to give her some gabapentin, and she basically said, well, I can't swallow any pills. It turns out we didn't have gabapentin liquid stocked in the preoperative area. It was in one machine on the 6th floor, and the nurses were not there. So needless to say, it delayed our case start by about 45 minutes, and our chief of staff, chief of anesthesia, and the surgeon were all trying to find me, but they could not find me because I'd locked myself in the bathroom. And so you have to think about all of these things as far as enteral feeding and medications. Setting expectations and stakeholder communication is always key. Again, like I talked about, getting folks to talk to each other and know that we're all on the same page and putting all those pieces of the puzzle together. Those things can all be accomplished preoperatively so that your intraoperative and your postoperative phases flow as smoothly as possible. So to conclude, when you start a pediatric ERAS pathway, you always want to identify the why. For us in Middle Tennessee, the why was to reduce opioid consumption. That was the big why for a lot of us. And so if you look at all of the opioid epidemic charts and graphs, you'll notice that where I work is the reddest of the red, which means the worst as far as opioid-related deaths and opioid-related misuse. And so that was a big driver for the why for us. Don't do ERAS in kids just to do ERAS, to say you do ERAS. Very clearly identify what risks you're trying to reduce or what you're trying to improve. You want to define the baseline. Again, like I said before, you don't know where you're going if you don't know where you started from, and if you don't know where you want to be, you have no idea what direction you're going. And so you have to know your baseline, know your length of stay baseline, know your opioid use baseline. All of those things are super important in pediatrics. Engage your stakeholders, celebrate early victories, build upon those successes, measure and improve. For that, thank you. I guess we could probably open it up for just a couple minutes of questions before we turn it over to Dr. Heiss.
If no one has a question, I have a question. So this is for you, Mehul, and then I'd like you to speak to it too, Drew. You talked about your ERAS patients receive less opioids in the hospital, which is, I think, well published and a great outcome. But you also said that they go home with less opioid prescriptions, and that's something that we struggle with. So do you educate, your residents or fellows or who writes those prescriptions? How do you educate them? How did you get to that end point? And then, Drew, are you doing anything to that end as well?
So we have a case that's going to discuss that might be helpful. I'm not trying, Mehul, you can answer the question, but Katie is loaded for bear. She's ready for this resonant conversation.
So that's a perfect segue.
Perfect.
We'll hold on.
Perfect. Can we have the slides for the next segment, please? So I'm going to fly past these a little bit so I can highlight this case right here. And Katie's going to comment on it, but before we start, could I have 2 volunteers? Would you volunteer? I want you to ask a question. And the question is going to be this. It has nothing to do with Morpheus. I just want to know what you learned or what you noticed about the case presentation. Would you do that? You're sitting behind Irving and perhaps the lady in the back row on the other side. I just want, you guys have been quiet and I know you're thinking and you're writing stuff down. I'd like to know what you guys learned from this case, okay? Skipping Morpheus. Okay, here we go. We have a 15-year-old patient who has a TI stricture. They drink Gatorade on the way to the hospital. They get Tylenol and GABA pre-op, and after induction, they get a QL block on the right and a rectus sheath block on the left. They get a single-site laparoscopic ileocectomy and are put on oral medications post-op. They drink and ambulate on post-op day 1. They get a stimulant, so they go to the bathroom, and they are met by a physical therapist and walked every 2 hours. And then by the evening of that first day, they've met their discharge criteria and they go home. So what did you guys notice? What did you notice? Any takers? Nobody is meeting my gaze. What did you notice? Irving, what did you notice? Help me out. Okay, really loud. Because I'll defer to my anesthesiologist, but I think it's because the ilium and the cecum are on the right-hand side, and they feel like the QL block may have better visceral penetration on the one side, whereas the rectus sheath block doesn't influence the retroperitoneum in the same way. Okay. I think it's because it was just a right-sided operation. That's why. Okay. What else did you notice?
Me, I'm a little bit biased because I know these cases, but it's fast. I mean, this is, being gone by post-op day 1 evening is really a fast discharge, which I think, when you're coming in with a TI stricture, I think it highlights a successful implementation of an ERAS pathway, but that's pretty quick.
Okay. Any other thoughts? I know you guys are thinking out there. I know you have something that you want to say. Okay, I'm going to change this and tell you this is best case scenario. I'm going to give you worst case scenario. Okay? Same patient. The evening of the operation, the patient is given orals, and you go home after having walked him a little bit. You come in the next morning, and the parents are really upset. The patient had pain all night long. The nurses called the residents. The residents would not give any narcotics because they didn't want to make the attending, okay, I can tell somebody's feeling the pain right here. They didn't want to give any narcotics because they didn't want to make Dr. Raval angry. And nobody wants to make Dr. Raval angry, okay? What do you notice? What happened here? Are any of you nurses? Any nursing staff? Okay. Have you ever been stuck between a parent and a resident who was not okay? This is a big deal, right? Any other thing that you notice? Because this is an implementation problem. If we don't fix this, the ERAS program is going to crash. No one's going to do it. Remember, when you're driving on the expressway, you only notice the cars that have accidents. You never notice the other million cars that you drive past successfully. Okay, comments? Katie, why don't you tell us a little bit about how to engage residents effectively in an enhanced recovery program?
So I just wanted to make a couple points about some realities that I've seen as a resident doing ERAS at multiple institutions that I work at as a resident, that some are a little more forward thinking in ERAS and those that aren't. I think number one is, and one thing that this sort of case highlights is your night coverage. Let's say you're not even day coverage. So let's say your night coverage, you're not taking not primarily responsible for this patient. You weren't in the operation. You're just night coverage. You come on. They tell you that the patient is, post-op ileocectomy. The resident who's doing your sign out doesn't necessarily tell you that this is like a quote-unquote ERAS patient. You just know that maybe the surgeon who did the case does do ERAS. And you're called to the bedside and the patient has a lot of pain. Now, the case could go either way, right? The case could go that you are concerned you don't want to give narcotics to the patient because you know that Dr. So-and-so avoids narcotics in his post-op ileoцectomies. The case could also go that you're also pushed to give pain medication, and you actually do give pain medication to the child, and the next day the attending says, what the heck happened? Why did you give narcotics to the child?
That was the PG version of what the attending said? Okay.
Yeah, and you're sort of get called into like a phone call, and you're sort of confused, and you're like, well, I just thought I was doing what was right for the child. I didn't realize that this was, against quote-unquote protocol. So the questions that I started thinking about were like, how do I deal with this as a resident, right? How do I manage what I think is best for a child versus what is like best for a quote-unquote protocol and compliance and adherence overall for these programs? So I just think couple of things I wanted to just touch on that I think are really important. And obviously the first one is going to be education. So as residents and working at different institutions with a lot of different surgeons, we're not always taught about ERAS. And even though I really think, just highlighting what other people already said, is that it needs to be sort of a way that we just see patient care, period. And it doesn't have to become like a different way, right? It's just the way we care for patients. But I do think right now in residency education, like we need to be starting with our interns during orientation. So that's just something to highlight. It's like kind of pushing forward during orientation with program directors. They need to be talking about, we have ERAS lines for X, Y, and Z, and this is what ERAS is in case this happens. Number two is like, I do think that it would be really worthwhile to start thinking about champion residents for ERAS. So for instance, like if we have a colorectal ERAS program, like is there a resident, doesn't necessarily matter what PGY level they are, but is there a resident in the program that's interested in quality improvement, and could they be an ERAS champion for that residency? And then therefore, would they be able to educate other residents and also help with like maybe data collection, stimulating research projects at the institution, and then garnering like more interest support from other co-residents. And then I think number two, so educate one, two, facilitate. So help us do what you guys want. So post-op order sets, pre-op order sets, I think are really important. And I think obviously also invoking collaboration with anesthesia. I've seen multiple times where anesthesia will DC pre-op order sets, and then it always comes back to us. It's always our fault, right? So somehow like this comes back to us that why didn't the patient get the pre-op meds? But unbeknownst to me, the anesthesia resident, or the anesthesiologist didn't think that patient should get gabapentin and Tylenol pre-op. So I think order sets can be really helpful, but also like, again, there needs to be some like teamwork around that when it comes to order sets. And also, number three, the other point is deviation. So what happens when protocols need to be deviated from, and when should residents still kind of adhere to protocols? And I don't think we talk about that enough, and we don't have like backup plans in place, and residents aren't instructed on like how to deal with that. And you can talk about pain management, but also fluid management. What happens when I have a patient on the floor who doesn't pee? Do I give them fluids, and how much volume do I give them, and how much volume is not safe to give them, and how do I not need to look at urinary output or tachycardia as indicators for when to manage these different problems?
Or in the absence of any physiologic findings, you just let them not pee.
Yeah. And is that okay to do? So these are just things that I think we need to talk about more as a resident level that can help with all of this implementation that goes on. And then the last point is feedback. So if we as residents are not given feedback on like how programs are progressing and improving, then I don't think that we can do a good job in like honestly like implementing a lot of these things. In the same field, like in the same vein as like all of these implementation programs in general, they need to be given feedback on compliance and adherence to protocols. I think residents also need to have some feedback as to like where they play into all of this. So those are just my 4 points that I wanted to touch on about resident education and how we can maybe improve our role in all of this.
Okay, so asking for volunteers did not work very well. So Matthias and Kyle, I'm going to present one more patient, and I would like you to be the commentators. And the question is, what did you notice? These are softball questions. Whatever you want, what did you notice and what did you learn? Okay, so here we go. We have a 1-year-old healthy boy who finds he has an incidental abdominal mass. He's hypertensive, so he gets an ultrasound MRI. He has a renal mass, he has no tumor thrombus, and he has a negative chest CT for pulmonary Mets. So he started on a medication for hypertension, and he's prepped for his nephrectomy. He gets a port placed, and he has a transverse incision, total nephrectomy, a retroperitoneal dissection with lymph nodes, so he is oncologically compliant. He gets a little stuff taken off the diaphragm. There's no transfusion. He goes to the PICU briefly for his hypertension and then is returned back to the floor on post-op day 1. What did you notice? What did you notice, Kyle?
I mean, did this patient receive any multimodal analgesia, like an epidural?
I can't hear you.
Epidural for pain control. I mean, what sort of things were done before and during the surgery to prepare the patient for recovery from that operation?
Okay, what would you do at your institution?
I mean, we would follow a lot of the same. We have a oncology protocol, basically, that starts outside the hospital, making sure they get a carbohydrate load. We have multimodal pain regimens.
So do they get epidurals or do they get blocks?
Epidurals.
Okay. In this institution, this individual has found that epidurals add 2 unanswered days to their length of stay, so they're using blocks and multimodal management. Okay. This patient goes home after 3 days after a nephrectomy. Matthias, what'd you notice?
I mean, I don't know about kids.
I know. You're an ERAS expert, so I'm just asking, what did you notice?
I would, an adult, probably wonder, was it worked up okay?
Oh, yeah. We're focused on the ERAS principles, not the oncology.
Just kidney and not the oncology. No, I mean, you give some pre-op multimodal medications still in this case, right? I would probably do more hemodynamic, at least monitoring.
Okay.
For this case, I totally agree with you. We don't do epidurals because we don't know how to. I mean, we know how to handle them, but we can't get it done post-op, which is why we don't do them. We don't even do blocks for these. They get neuroanatomical infiltration with liposomal bupivacaine. We don't even have an ERAS protocol for nephrectomies. They get ERAS light. They get, when they're lucky, an anesthesiologist who will order the multimodals pre-op. And their surgeon is usually pretty on top of things, so they might have had some clear liquid of some sort that has some electrolytes, that does not carb load, but at least keeps them hydrated.
Okay. So,
Quick question. What about use of ketorolac?
Thank you. So I didn't put that in the presentation, but the individual got ketorolac for 48 hours. How would you guys, as a urologist, how would you feel about that?
I think there's still disagreement with some of my colleagues about it. I personally would feel okay with it. I think if a patient has a normal contralateral kidney, I think the risk of sort of worsening acute kidney injury is quite low. I mean, you're always going to see a creatinine bump after you take out a kidney, but that's because you removed a kidney, not because you're giving them ketorolac.
So at this institution, the surgeon has engaged the nephrologist preoperatively, and the nephrologist and the anesthesiologist and the surgeon have all agreed that ketorolac for 48 hours is the rule, not the exception. And so they've addressed that.
That's great.
Okay. Okay. Any other comments on this? This is an open case. They got a block. It was an oncology procedure. It's not IBD or a gallbladder or something like that. Any other things that you noticed about it? Yeah. So I would guess, I'm going to defer to my anesthesiologist, if there were 100 anesthesia teams in the United States that dealt with pediatrics, how many of them are approved to use Exparel in their hospital for children right now?
Well, I can tackle two of those questions here. You know, the first thing is that it makes my heart heavy that this child did not get an epidural. I think an open resection for a tumor and having that resected in my book is an epidural all day, every day. I think, you know, a block would be very short-lived, especially for a child that young, 1 year old. And so we do epidurals for all of them. And, you know, to address your point about the epidurals being left in for a couple days and increasing length of stay, and that is the fog of war that I've talked about before, is that we don't know what those transition points. That's a surgery team that's not communicating with the anesthesia team, that's not communicating with the pain team about goals, right? And so the minute that child gets clear liquids and they can transition, having those streams of communication is important. Yes, any catheter that's in the body can increase length of stay, whether it's your urinary catheter, an epidural catheter, a paravertebral catheter, doesn't matter if all teams are not aligned on the right goals. And so that's the first thing. And then Exparel was actually FDA approved for children, I believe it's 6 and older. 6 and older as well. And so there's very little data to support the efficacy of Exparel in children. What we have so far in children that are older than 6 is safety data. Kids under the age of 6, we don't have any idea. But as far as efficacy goes, there's very little data to suggest that it's reduces length of stay, reduces opioid consumption, anything for children. The other caveat is it's very expensive. It's very expensive. It can actually cost more. We actually looked at this, and the cost of Exparel was actually going to be more than the anesthesia services that I would provide for this child for 6 hours in the operating room, keeping him alive. And so I'm not sure that's good math for the organization.
Is a single shot regional anesthetic an acceptable thing as opposed to an indwelling catheter for a patient like this?
Again, I think it's a good piece of the pie. It's just one piece of the pie. It's not the pie. So I think if you just did a block and you did nothing else, and you didn't incorporate the multimodals into there, I think you could have done it better. But yes, I think adding a block is better than not adding a block, even though an epidural, in my opinion, would be the best.
Do you want to stop now, or do you want to?
Well, so I think we can probably take the rest of this stuff offline. We're going to start the second part of our series today at 10:30, but this will give you guys about 15 minutes or so to go do a coffee break. We'll hang around, and if you guys want to just talk with us about any details or anything else for your institution, I think that would be great. At this point, I just want to thank everyone up here that did an amazing job talking about ERAS Pediatrics. And again, get involved, talk to us. We're a growing fledgling society of ERAS USA, and there are a lot of opportunities for you guys to be involved with us, and we're happy to talk to you about how to get ERAS to your pediatric patients. Thank you.